He is a senior consultant of medicine, diabetology and non-interventional cardiologist. He is president of Indian Diabetes and Cardiometabolic Disease Association, chairman and organizing committee IDCM. He is vice president of the association. It's a long list, but the important one is book author of Management of Diabetes and Mellitus, a complete practical guide, and having so many book chapters, even in Sanjay textbook of diabetes ICP. Over to Dr. AKASH.
Thank you very much. It was a pleasure meeting you all, and I thank you all for inviting me for this. I will be talking about hypoglycemia, and I will be mainly concentrating on hypoglycemia in diabetic individuals. Now, hypoglycemia in simple terms is defined as low blood sugars, and there is a Weber's trials will give a definitive definition of hypoglycemia, that is documentation of low blood sugar, presence of symptoms, and reversal of symptoms when blood glucose levels are restored to normal. Now, ADA has graded hypoglycemia into 3 categories, and this has been agreed upon by AAC and others in the diabetic field. Level 1 is less than 70 mg, that is hypoglycemia alert, you should immediately tackle it. Less than 54 is serious hypoglycemia, and that is clinically significant hypoglycemia. Level 3 is no specific glucose level, but patient is having all the symptoms of hypoglycemia, is unable to assist himself, has severe cognitive impairment, and has to be helped by others to bring him out of this condition. So that level 2 and level 3 are most undesirable forms of hypoglycemia. So severe hypoglycemia, as you have seen, assistance of another person, documented symptomatic hypoglycemia, typical symptoms, blood glucose less than 70, asymptomatic hypoglycemia, those patients who develop hypoglycemia unawareness, or younger population, no symptoms, even if the blood sugar is less than 70. Probable symptomatic hypoglycemia, where the patient has symptoms suggestive of hypoglycemia, but you have not documented, you have not done sugar, he directly has taken, so he reports this to you, so that is probable symptomatic hypoglycemia. And there is something as pseudo hypoglycemia, where there are typical symptoms, but the blood sugars are less than or more than 70. And when does this happen? Suppose a patient has a sugar of 300, he is keeping the sugars at 300 for a longer time, he comes to you, you go for aggressive control, you bring it directly from 300 to 100 or 90, and that is a maladjustment to the body to the sudden decrease in sugars, which leads to condition of pseudo hypoglycemia. So if a patient is comparing of symptoms of hypoglycemia and the sugar is 100, 110, don't disregard it, that is pseudo hypoglycemia. Now what does the insulin do is to increase the glucose uptake, glycolysis is increased, glycogenosynthesis is increased, triglyceride synthesis is increased, and protein synthesis is increased. So it is an anabolic hormone. So when it is decreased, there is glycogenolysis, gluconeogenesis, the beta oxidation of free fatty acids, ketogenesis, and proteolysis. So this is insulin, and the opposite effect is seen with glucagon, epinephrine, cortisol, and growth hormone. Now the problem with hypoglycemia is that hypoglycemia is often the major limiting factor in the glycemic management of type 1 and type 2 diabetes. If you see the hospital admissions for hypoglycemia, they are much more than hospital admissions for hyperglycemia. So hypoglycemia is a more serious emergency which is seen day in and day out. It is a general conception that type 1 diabetics are more prone for hypoglycemia, but type 1 diabetics are very less in number. The prevalence and the numbers for type 2 are huge basically, and majority of the patients of hypoglycemia that you encounter will be having type 2 diabetes. The strategy that lower is better does not hold true. Lower without hypoglycemia, the lowest level is the strategy now. You have to avoid hypoglycemia at any cost, and that is the primary objective of diabetes management. However, some patients who have HbA1c on the higher side, but who have more of glycemic variability, can have a higher incidence of hypoglycemia. Now, diabetic agents are implicated in 13% of emergency department visits for adverse drug effects, and of these 90% of the cases are associated with hypoglycemia, and of these cases 39% cases result in hospitalization. And let me tell you, a lot of these hospitalizations are in ICU, entail a lot of cost and a loss of phobia to the patient regarding diabetes management, and a lot of economic constraint to the family and the society at large. So we have to avoid hypoglycemia at any cost. There are several causes of hypoglycemia. I will not dwell into all because it's a long list, but a new onset of exercise, a sudden tendency to reduce weight or to decrease food intake, or gastroparesis, depression, alcohol intake, NPO status, secure dogs, insulins, endocrine causes, chronic kidney liver disease, multiple medications for diabetes, hypoglycemia, unawareness, cognitive impairment, and higher glycemic variability, all are important causes of hypoglycemia. Now the reason for hypoglycemia due to hepatic disease is, in chronic hepatic disease, this glycogen storage is gone, basically, impaired gluconeogenesis, and this leads to increased propensity for hypoglycemia. In renal failure, you have again decreased renal gluconeogenesis because once the hypoglycemia occurs, initially the renal component of gluconeogenesis is less, but as it is protected, the renal component becomes important. So there is decreased renal gluconeogenesis, decreased calorie intake in patients of CKD or acute kidney injury, decreased renal clearance of insulin and other medications, which leads to hypoglycemia. Now, alcohol-induced hypoglycemia occurs when the patient keeps on drinking and takes less food, so the glycogen is depleted and there is an impaired gluconeogenesis, and this leads to hypoglycemia. Prolonged exercise can cause hypoglycemia because of the excessive consumption of calories and depletion of the muscle glycogen, and there is an insulin independent intake of consumption of glucose, which occurs with exercise, and therefore patients with endurance exercises or long duration exercises can develop hypoglycemia. Critical illnesses can also cause hypoglycemia because they may impair hepatic and renal function. They also may lead to higher catabolic state, higher demand of sugars, and there is a glycogen depletion because of poor oral intake, and some illnesses can also cause cortisol insufficiency. All of this can cause hypoglycemia. Addison disease, though rare, is likely due to cortisol deficiency that interferes with counter-regulatory responses during times of stress. Cortisol is an important counter hypoglycemia hormone. Now there are several drugs, mainly insulin, secretagogues, alcohol, quinolones, quinine, quinidine, all of these are important, hydroxychloroquine, which can cause hypoglycemia. Then there are some other causes of hypoglycemia because of increased insulin sensitivity, insulinomas, non-ICS tumors, some mimics of insulin like IGF-2, all of these basically also can cause hypoglycemia. Then there is something called as reactive hypoglycemia because this is because of hyperplasia or hypertrophy of the beta cells, or because of increased sensitivity to insulin, and this can be seen after bariatric surgery, or it can be seen with insulin antibodies or insulin receptor antibodies. So the pathophysiological changes are inflammatory cascade is activated, there are more inflammatory markers, endothelial dysfunction is there, and pro-thrombotic state develops, and there is a sympathoadrenal response. All of this basically complicates the patient and can lead to excess severity and such conditions. So the consequences of hypoglycemia is a stress response. Their symptoms may be confusion, coma, impaired memory, loss of awareness, a fear of hypoglycemia, preventing effective management of diabetes, psychological impact, social impact, economical impact, risk of death, impact on heart, and accidents, employment problems, cardiovascular risk, everything is because of this. Now coming to the intensive glycemic control, there are several trials studied this, and of this VADODARA, AKASH, and trials basically they saw that intensive control is associated with a higher risk of severe events, and this basically led to the theory that intensive control is not desirable. We should go for an optimal control. But these trials were done in the era when we did not have the modern medications. We have a lot of new medications now where we can have good control of sugars without causing hypoglycemia. These were done in the era where secretagogues and insulins were more commonly used. Severe hypoglycemia was shown basically in intensive group, as you can see in the blue bars. In VAD history of severe hypoglycemia, strongest independent predictor of mortality at 90 days records severe hypoglycemia associated with increased mortality, but to a greater extent than those in standard groups. Advanced severe hypoglycemia associated with increased mortality at mean of 1.05 years. So this is the micro and macrovascular events are increased with hypoglycemia. Death from any cause, cardiovascular cause, non-cardiovascular cause, everything is increased with hypoglycemia. But one-to-one relationship between hypoglycemia and these events is not possible to show. It is possible that severe hypoglycemia does not directly contribute to the adverse outcomes, but merely be a marker of vulnerability of such events. It is like HDL cholesterol. Low HDL cholesterol independently does not predict cardiovascular events. It is a marker of cardiovascular event. So, hypoglycemia increased vulnerability of the patients to these cardiac and non-cardiac complications and outcomes. This is the trial which I want you to remember. Now, severe hypoglycemia, CVD, 6 individual studies with more than 9 lakh participants with 1 to 6 years of follow-up. Severe hypoglycemia is strongly associated with high risk of CVD. Bias analysis found that comorbid illness alone did not explain the association between hypoglycemia and CVD. So conclusion was severe hypoglycemia is associated with a higher risk of cardiovascular disease in this meta-analysis. Now consequences of hypoglycemia are clinically important in different ways. If there are repeated episodes of hypoglycemia, then the patient can go into something called as HAF, hypoglycemia autonomic dysfunction, which impairs the ability, the response of hypoglycemia, the autonomic response of hypoglycemia. So patient will directly go to neuroglycopenic symptoms and will directly go to confusion, coma, which is not desirable. The precursor symptoms are not there. If it is in a poorly controlled patient, then the symptoms may be severe and prolonged asymptomatic episodes overnight can lead to acute internal abnormalities, arrhythmias, and may lead to CVD events. So the autonomic symptoms are sweating, anxiety, tremors, palpitation, hunger, tingling, ill-defined symptoms, and neuroglycopenic symptoms are basically related to blood vision, confusion, difficulties feeling, dizziness, lightheadedness, lethargy, weakness, seizures, coma. So you can see that once the sugar drops to around 80 to 85, this is a better, then initially the insulin levels go down. That promotes further, prevents further decrease in sugars. Once they go down to around 68.4, then the counter-regulatory hormones kick in, that is glucagon, epinephrine. If it still goes down to 57.6 to 50.4, onset of symptoms which are autonomic and neuroglycopenic, at this moment the person recognizes that something is wrong and he tends to eat the sweets to prevent it. If still something is not done, then patient can get neurophysiological dysfunction, evoked responses, widespread EEG changes, cognitive dysfunction, inability to perform complex tasks, and he can lapse into reduced consciousness, coma. So anything below 40 is very, very dangerous. Anything below 25, patient can lose his life. So the challenge is that we cannot study the effects of hypoglycemia because it is not possible to induce these low levels of sugars and study their effects on the human body. So the correlation of low sugars with changes, the experimental studies cannot be done. Cardiac events are rare. Severe hypoglycemia is an uncommon problem in many individuals. Accuracy of CGM during hypoglycemia has been reported to be uncertain because at very low sugars you will not have the exact reading. Older individuals are at higher risk of hypoglycemia. Old age, prior hypoglycemic episodes, polypharmacy, age-related changes with pharmacoitis, pyotitis, clinical conditions, including decreased hormone regulation and counter-regulation, suboptimal intake of water or food, decreased intestinal absorption, cognitive impairment of the liver and kidney function, everything contributes to hypoglycemia. And therefore, the ADA in the Standards of Care 2024 has said that every patient who comes to should take history of hypoglycemia, should screen all individuals for hypoglycemia. Glucose is the preferred treatment for conscious individuals with glucose less than 70. They should receive structured education for hypoglycemia for prevention and further treatment. And we should de-intensify complex regimens, pre-intensify the present regimens, and you should change the medications if such thing occurs. So major risk factors for hypoglycemia is the number of hypoglycemia events which has occurred in this patient, insulin treatment, supplement treatment, age, CKD stage, and number of emergency department visits in the previous year. And accordingly, the scale has been made for hypoglycemia risk category 2, in which we can classify the patient as having high risk or low risk. The components of hypoglycemia prevention for individuals at risk for hypoglycemia at initial follow-up and annual visits. You have to see the hypoglycemic history assessment, hypoglycemic awareness assessment, cognitive function and other hypoglycemic risk factor assessment, structured patient institution for hypoglycemia, prevention treatment, consideration of continuous glucose monitoring needs, re-evaluation of diabetic treatment plan with de-intensification, supplementation and agent modification as appropriate, glucagon prescription and training to re-establish awareness of hypoglycemia. So the challenges of measuring glucose levels is, if you go for SMBG will not predict the risk of hypoglycemia because it is a one-point measurement. So basically you have to go for continuous glucose monitoring if you are to actually accurately predict the risk of hypoglycemia. Risk factors of hypoglycemia: older individuals, they tend to have less of autonomic activity, autonomic symptoms, and they present directly with neuroglycopenic symptoms, which basically may not, because a lot of them will have dementia, a lot of them basically may not be well attended by their younger colleagues, because a lot of elderly people stay alone now, and this can lead to late realization that they are having hypoglycemia, and CVD and CKD have been shown to be a strong risk factor for hypoglycemia in older age. So they are more prone, and hypoglycemia in them is more serious. So we have the challenge in the form of that hypoglycemic episodes lead to acute and long-term cognitive changes, serious cause, cardiac arrhythmias, MIs, fatality, possible death, and treatment of older adults with diabetes is complex because they are heterogeneous, because a lot of comorbidities are there, and there are a lot of social factors, emotional factors, economical factors, life expectancy also may be limited. So all of these are challenging factors basically. So ADA recommends that we have to individualize pharmacological therapy in this patient population to reduce the risk of hypoglycemia, avoid over-treatment, simplify complex regimens, HbA1c less than 7 for healthy adults, and less than 8 to 8.5 adults with multiple comorbidities and cognitive impairments. And for this chart has been devised the health status, well, complex, very complex, or poor health, and the life expectancy. You can set the goal to less than 7.5, less than 8, or less than 8.5. You can also look at the life expectancy, which is very less. Then you can set higher goals compared to those individuals which have a higher life expectancy. Also, these individuals who are at high risk of hypoglycemia may be treated with metformin, GLP-1 receptor agonist, DPP-4 inhibitors, and SGLT inhibitors, and pioglitazone and imaglimin are the newer modalities with which we can treat these individuals. Hospitalization for hypoglycemia in adults with their subsequent transition of home. In patients with diabetes and over age more than 80 years, severe hypoglycemia accounts for 1 in 6 hospital admissions. Older patients may have cognitive problems, functional limitations, pain, and complex treatment regimens, all of which can result in inadequate symptom management and poor transition outcomes. So improving patient outcomes and reducing healthcare costs are both important goals in managing any chronic disease, including diabetes. Now, recurrent hypoglycemia leads to cellular adaptation and hypoglycemia associated autonomic failure. And once this occurs, the autonomic symptoms are not there. Patient will lapse directly into neuroglycopenic symptoms, which is not desirable. And once the patient develops half, the best strategy is to bring up the blood sugars to normal levels or little less, more than normal levels, and keep it there at normal or just above normal levels for at least 2 to 3 weeks. And during these 2 to 3 weeks, the autonomic dysfunction recovers and the patient is free from HAF, which is again a related complication. And this does not occur if patient has diabetic autonomic neuropathy. So difference between HAF and diabetic autonomic neuropathy is that HAF is reversible and and diabetic autonomic neuropathy is not that reversible. So with this strategy, you can restore the autonomic function of the patient. So to summarize, diabetes complexity, diabetes duration, impaired hypoglycemic awareness, high glycemic variability, prior hypoglycemic events, glycemic control, plays J-shaped relationship with HbA1c. If you go too low, you can develop more morbidity and mortality, fear of hypoglycemia, fear of hyperglycemia. All of this leads to complexity management of these patients, multimorbidity, functional impairment, frailty, comorbid health conditions, microvascular complications, macrovascular complications, cognitive impairment, dementia, everything complicates the management of these patients. Pharmacotherapy, high-risk medications like insulin sulfonylureas, other medications which also affect sugars going on in these patients, glucose-lowering polypharmacy, non-diabetic medications, complex treatment regimens, medication misadventures, all of this can lead to hypoglycemia and related complications. Patient context and environment, inadequate caregiver support or supervision, food insecurity, poor health literacy, financial burden, non-clinical or competing clinical demands, fasting either for medical tests, procedures or personal religious decisions, again leads to difficulties management of diabetes patient, healthcare system. There are no performance measurements, reporting and benchmark that focus on lowering HbA1c, inadequate diabetes support, resources including diabetes, self-management, education and clinical monitoring, payer decisions regarding DSMA, glucose monitoring, drug pharmacy and diabetes technology, because the insurance companies are not paying for that. They are not even paying for continuous glucose monitoring also. Lack of integration of patient health information, including glucose monitoring data and self-reported hypoglycemia into clinical EHR. Everything is there. So data is not there, information is not there, proper education is not there. Everything complicates diabetic management and leads to more, all the more reasons for hypoglycemia. So key takeaways: common occurrence in patients with diabetes, insulin and semaglutide confer the highest risk of hypoglycemia among clinical pharmacological treatment options. Effective patient self-management is essential to reduce risk and consequences. Empowering patients with education, tools, awareness, and an individualized plan of treatment to reduce the risk of hypoglycemia. Goal is to decrease the frequency and severity of hypoglycemic episodes, as well as improving quality of life and health outcomes. Thank you very much.